My name is Jim Wright, and thank you for the opportunity to talk with you today. I have one conflict of interest related to a textbook I wrote, which I'll be discussing later on in our conversation. I work at this hospital, which is the Hospital for Sick Children, which is in Toronto. This is Canada's largest teaching hospital. This is a watercolor of the hospital painted by Dr. Mercer Rang, who was a colleague of mine for many years, and some of you may have known him. And this is also where Bob Salter spent his entire professional career. I'm going to tell you a story today, but I'm going to start with a bit of a warning. I'm here to talk to you about how we establish best practice in orthopedics and to try and challenge your thinking on this. I will tell you, however, that this talk is grounded in my passion for the practice of orthopedics and my unshakable belief that orthopedic surgeons want to do the best things for their patients. So the story begins in 1999. I'd been in practice for about 10 years. I've been involved in some research, but I began to compare our practice of orthopedics with other disciplines, specifically the medical disciplines, and recognize that they establish best practice differently than we do in orthopedics. At the time, there was an acceptance and even a promotion of divergence in opinions about treatment recommendations. For every treatment I treated, there were sometimes 5, sometimes 10 different treatments that you could use for a particular patient. Also, there was the unquestioning acceptance of the opinions of senior colleagues. And although I had great respect for these senior colleagues, they differed amongst themselves just as much as everyone else. So for me as a practicing surgeon, it became very difficult in knowing what was the best thing to do for patients. And I think we got there. My supposition is based on the reliance on the uncontrolled case series, which at the time was the main form of literature. So where was the state of the literature in 1999? This is work done by Mo Bandari, looking at the number of randomized clinical trials published in the Journal of Bone and Joint Surgery America. And the black dots along the bottom represent the percentage of studies. Well, it looked as if in the 90s maybe there were more randomized clinical trials being published. If you look at the end, at the turn of the millennium, we were publishing between 1% and 3% of articles published in JBJS were randomized clinical trials. So how is it that case series got us to this point that there were so many treatments for every condition? Well, you may be familiar with this phenomenon which is called regression to the mean. So I have back pain, low back pain. Some days I can barely get out of bed. Other days I feel great. I have absolutely no pain. But most days it's there. I feel it when I get up in the morning. So the days when it's really bad, I wait, because I know it's going to get better in a couple of days, and those days where it feels fantastic, I don't think it's gone away because I know in a couple of days it's going to come back. So that's the regression to the mean. Well, what if you're a patient? When do you present to your physician? Well, you present when you have those symptoms. You present at the peak. And I've tried to convince you that if we wait, well, those symptoms will get better. Even if there's no treatment, a patient with symptoms, and that's a lot of what we do in orthopedics, will improve. Well, what happens if we treat the patient at the same point? Well, they'll also improve. Irrespective of the treatment, they would have gotten better already. As Bob Salter used to say, the best way to end up with a good result is to start with one. So if we were to do a case series and assemble all these patients together, we have a treatment group. We might conclude that these group of patients get better with time. You'll see that there's no control group. So we might conclude that this treatment, even if patients were going to get better on their own, got better because of the treatment. So I call this the Turkelson phenomenon. Some of you may know Charlie Turkelson, who works at the American Academy of Orthopedic Surgery, and I borrowed these slides from him. And he calls this the life cycle, a cynic's view. Dr. Smith publishes a case series that shows, because of regression to the mean, the device reduces pain. Because Dr. Smith is an expert, his patient gets a lot of attention. Someone replicates Dr. Smith's findings in another retrospective case series. Dr. Smith is or becomes affiliated with a manufacturer. The manufacturer begins to market the device. Lectures are given on how well the device works. Some case series, however, find that the device doesn't work. But journals won't publish results because no one's really interested in statistically non-significant findings, so-called negative studies. Meanwhile, more case series are published which replicate the results. More and more physicians try the result, and they too see that patients get better because of regression to the mean after using it. The patients also feel like they're getting better, and the doctors reinforce the notion this is because the device works so well. Manufacturers contact patients and get some of them to provide testimonials. The device now becomes yet another accepted medical device or option for the patient with whatever condition. The evidence base for it now consists of multiple case series, level 4, physician experience, level 5, patient testimonials, and marketing material. This is what I call opinion-based practice, and George W. Bush said it best. I know what I believe, and I believe what I believe is right. And this all comes to a halt when a well-published randomized controlled trial showing that the device is no longer better than placebo or medical management. So to take you back to the case series, we don't have a control group. What if we had a control group? And the control group looked like this. It's the same group of patients, but without any treatment, they would have got better all on their own. And the conclusion would be that the treatment's probably not very helpful. Well, this is a controversial example, but many of you, even if you aren't spine surgeons, will be familiar with these two studies that were published first and second in the New England Journal about 2 years ago, looking at the use of vertebroplasty. And Michelle Bookbinder concluded we found no beneficial effect of vertebroplasty as compared with a sham procedure in patients with painful osteoporotic vertebral fractures. Now, I don't mean to say this study solves this question definitively, but and the answer clearly that may be it's appropriate in some patients, but it must cause us pause because $1 billion worth of these procedures are being done in the United States alone every year. So I don't mean to say that there's no role for a case series. In fact, some of our greatest advances in orthopedics come from case series. So take yourselves through this little thought experiment. What are the things that have dramatically changed patient outcomes where we all agree patients are clearly beneficial than they were before? And I will suggest to you that there's at least 4 examples that I can come up with. Total joint replacement, John Charnley, 1973. Internal fixation of fractures, the AO group in the late 50s. Paul Harrington, instrumentation for the spine, and in my own field of pediatric orthopedics, Ignacio Poncetti, the treatment for club feet. So I show you the slide to say that clearly there are and have been indications for case series. But I get you to reflect on the past 30 years. Can you come up with other examples where we've made such huge gains in patient outcome? We've changed, we've come up with new treatments. But how many of you can come up with examples where we've really changed the quality of care, where we've really improved patients to the same degree? The analogy I like to use is low-hanging fruit. So the 4 examples I showed you were low-hanging fruit. It was clearly obvious that they were better than anything else. The problem is we picked all those low-hanging fruit. So in order to get the high-hanging fruit, we need to do something different than a case series. We need to come up with another paradigm. We'll enter evidence-based medicine, and it was defined by Dave Sackett as the current best evidence, and he meant randomized trials from systematic research and making decisions about the care of individual patients. This is what we aspire to, but he doesn't tell us how. And that's what I want to tell you about. But I briefly want to digress because this has largely been accepted on faith. We do randomized trials, we get better evidence, we implement it in patients, and they have better outcomes. So I find this an astoundingly compelling example, and it comes from pediatric oncology. 30 years ago, pediatric oncologists were just like orthopedic surgeons 10 years ago. Their literature was based on case series and personal opinion. Only 10% of children with malignancy survived. About 30 years ago, they said is enough, and they got together and began to perform randomized clinical trials, which is now part of the clinical oncology group. It's estimated in North America that 75% of every child, that's every child in North America, who has a pediatric malignancy is entered into a clinical trial, and there's 50 ongoing at any one time. And over the past 30 years, survival has gone from 10 to 70%. And they hope by the end of the current decade, they will have cured pediatric malignancy, all through randomized clinical trials. So I find this a compelling example. So if you accept this as a burning platform, what would this actually mean? Well, to take you back to 1999, I began to think, well, maybe if this is going to work, we would need to promote it in the evidence in journals. We would need to promote evidence in professional societies. We would need to develop more evidence through specialty-based randomized clinical trials, societies such as this one. We would need to build capacity in understanding, designing trials, and we would need to bring evidence in an accessible form so it could be used by orthopedic surgeons. And that's the story I want to tell you. So beginning first with the Journal of Bone and Joint Surgery, in the late 90s, Jim Heckman took over as the editor. He was very interested in changing the journal and promoting this concept of evidence-based surgery. So we created this section called the evidence-based section. We're about to publish our 50th installment. Brian Haynes and his group reviews 40 journals every month, and every 3 months I receive a packet of all level 1 evidence in these 40 journals. Mark Swinkowski and I pick 3 of the most timely and compelling, and we publish these articles with a commentary. So here's one. This is from Margaret McQueen's group looking at the use of screw fixation for scaphoid fracture, showing surgery is better than no surgery. And I solicit a commentary, in this case Graham King from the University of Western Ontario. So every 3 months, orthopedic surgeons can turn to JBJS and turn to this section to find out the latest evidence published in journals other than JBJS. The next thing we instituted, and probably the most controversial, is this idea of levels of evidence. Now, this concept also comes from McMaster, but a group from the American Academy and JBJS developed a level of evidence for the 4 types of studies: therapeutic, prognostic, diagnostic, and economic analysis. And then we create a criteria which are relatively simple to use. So every study is graded 1 through 5. And a level 1 therapeutic study is a well-performed randomized clinical trial. So I review every article published in JBJS, and at the end of the abstract is the level of evidence. And it had 3 purposes. 1, for people submitting to the JBJS, they had to submit a level of evidence, so they begin to understand about the methodology. 2, the reviewers, they determine what gets in the journal, so they're beginning to understand the level of evidence. And most importantly, it's for the reader. Now, levels of evidence is a simplistic, clearly you would need to do a critical appraisal for the entire article, but it places the article immediately in context that you as the reader would probably want to spend more time looking at a level 1 study. The idea here is that as you go from level 5 to level 4, particularly when you get to level 1, it's a higher quality study and it's more likely to give you the answer to the question, which treatment is better? The last change we implemented into the journal with the help of Tom Einhorn is all the review articles, the current concepts at the end of the journal, use this thing called grades of recommendation. So level of evidence is for 1 study, but clearly there's a bunch of studies published on any clinical question. So grade A is good evidence, and this is something you definitely should be doing for your patients. Grade B is fair evidence. This is probably something you should be doing. And level C is poorer quality evidence. This is something you could be doing. And I is no information. And this is used both in the journal, and it's also used for the development of practice guidelines by the American Academy, which has been very active in this area. This hasn't been welcomed with enthusiasm by everyone. Frank Horan, a former editor of the British Journal of Bone and Joint, published this editorial. We simply require the soundest evidence available to influence our surgical decisions. Whether the current attempts at grading papers, levels of evidence, are reasonable is a matter for individual decision. Perhaps we need to consider whether it's appropriate to assess the value of a parachute by a randomized controlled trial. And in the parachute versus the placebo, I think that Mr. Horan was thinking that I might have been in the placebo group. Despite the legitimate concerns, this has now been picked up by 6 other orthopedic journals, and this levels of evidence concept has had a much bigger impact on orthopedics than I ever could have anticipated. I'm a proud member of the Pediatric Orthopedic Society member and also a member of this organization, but I believe the specialty societies have a unique role in promoting evidence. So I've worked with 5 presidents of POSNA, one's in the audience today, John Dormans, who've been very supportive of the idea of evidence and its role in our specialty society. So like the JBGS, we require all authors to submit a level of evidence rating with their abstracts. So the submitters are beginning to understand levels of evidence of all about. And for many years, I graded every abstract. So again, the abstract book, the reader has the opportunity to look and say, well, this is a level 1 evidence. I probably should go and hear that talk. But more importantly is we need more clinical trials. The basis of this is we have good information, and I believe the specialty societies is the most appropriate place for clinical trials. I live in a country which has the Canadian Orthopaedic Trauma Association, which many of you may be familiar with, and this group has been particularly active and particularly influential in doing randomized clinical trials, which I think are changing the face of trauma. In pediatric orthopedics, we couldn't tackle the really big problem first, so we wanted to start with something relatively straightforward, easily diagnosed, looking for a simple treatment, a straightforward and short-term outcome, and then an idea of multiple centers with few patients. And I'm particularly proud of this trial, which we published in 2008 in JBGS, looking at 2 treatments, interlesional treatments for simple treatment of bone cysts. Interestingly, the first case series published on the use of bone marrow in simple bone cysts had 100% success. What we found is although the rate of healing of simple bone cysts was low in both groups, in fact, we found the traditional treatment of methylprednisolone was superior. And this involved 30 surgeons and 25 centers, and I think it shows the power of a specialty society to come together around a clinical question. I believe that not everyone has the time. I took time away from my training to get a degree in clinical epidemiology. Not everyone has that time or commitment. So with the support of Mark Swinkowski and the American Orthopedic Association, we developed a curriculum to help people learn about clinical trials. This is a 22-module course. Each of them is a 1-hour lecture. So 10 core, 12 advanced topics. And this is available on the AOA website. Recognizing that not every center would have an expert in clinical trials, we specifically designed the course for junior faculty and for residents, and it could be taught by a non-expert. So you don't have to know all about clinical trials to teach this course. And we also develop a multiple choice questions so you can assess people's learning. These are the 10 basic modules that allow people to design clinical trials. And we did a pilot study in JBGS among 3 groups of residents to show we could substantially increase their knowledge with just these 10 modules. So where do we stand today? There are many parameters that I could show you that lead me to believe that evidence in orthopedics is on the dramatic rise. But I'll take you back to 2000 when it looked as if there were no randomized clinical trials being published in orthopedics. This is an article published in late 2009. The red bar represents randomized clinical trials. We're now up to almost 25% of articles published in the JBGS American are randomized clinical trials. But you see the purple and the green, which are other level 2, prospective and retrospective controlled non-randomized trials, are also on the rise. Together, for the first time in JBGS American, less than 50% of the studies published are case series. And I'm currently trying to convince the current editor, Vern Tolo, that we should stop publishing case series in the JBGS American. Stay tuned, a controversial suggestion. So the last thing I want to talk to you about is bringing evidence that would be accessible to orthopedic surgeons. And this is my conflict of interest. I receive a fairly meager royalty on any books sold related to this particular textbook. So I do need to alert you that I have that conflict. In 1998, we published this book called Evidence-Based Orthopedics, The Best Answers to Clinical Questions. And this is a 100-chapter book which is focused on what I call nagging clinical questions. These would be clinical questions. These would be dilemmas that would happen to a general orthopedic surgeon more than once a year. Now, some of these questions would come up every week. Some of them would come up once a year. So we chose 100 clinical questions. So every chapter is written as a clinical question. What's the best treatment for femur fractures in children? What's the best treatment for osteoarthritis of the shoulder in the elderly? Every chapter is written as a question. But we did something different than previous textbooks. We did systematic literature reviews. I had an evidence analyst systematically review the literature to identify controlled studies, level 1, 2, and 3, no case series. So every chapter was informed by controlled studies, and it was done in a systematic way. With each chapter has a grades of recommendation table. So if you want to open up the chapter, look at the title, and get the answer, there's a grades of recommendation table. So in every table is the answers to the question of what's the best treatment for this. And along with those treatment recommendations is a grade, A, B, C, or I. So to give the reader some idea. So if you want the answer, you open the chapter, you turn to that table. Something else we did is we provided the search strategies. This was published in 1988. I'm told your trials are coming out. So if you want to identify the literature since this textbook was published, with the textbook comes the search strategies. So you can apply the search strategies to the literature so that you can see what articles have been published. Controlled studies have been published since the chapter was written. So the hope is not only would this bring evidence to surgeons and make it more accessible, but we also hope this will begin to influence the way textbooks are written. So they'll be more systematic in their approach and do so from an evidence perspective. However, clearly this is not the way of the future. This is the way of the future, your smartphone. Some of you may be familiar or have seen advertisements for this software. It's called Extra Credit. From your phone, you can do a search on a clinical question, and you can get credit for continuing medical education, which is important in North America for recertification. Now, unfortunately, the answers you get are not necessarily evidence-based. But I believe within 5 years, you will be able to have in your hand a smartphone that allows you to get an evidence-based answer to your clinical question at the bedside in real time. I think we're about 5 years away. And then we can all burn the textbooks. So, to conclude today, hopefully I've challenged some of your assumptions. I believe that high-quality evidence is increasing in orthopedics. The number of randomized clinical trials and controlled trials is clearly on the rise. I would suggest to you the culture of orthopedics is becoming evidence-based. I think we've gone beyond the tipping point. We are not going to go backwards. In North America, the major move is towards improving quality. If nothing else, because we have to get a handle on the cost of care. The underpinning of quality care is good evidence. This is clearly happening in orthopedics. To answer the question posed by the title, what does evidence-based orthopedic means? Well, I think it means using evidence for the care of individual patients, but it means influencing journals, specialty societies such as our society, CCOT, and other societies, writing textbooks in a fundamentally different way, and providing evidence so that you surgeons can deliver care, and also possibly patients. I haven't talked about patients, but patients are a very potent force. And I would like to suggest to you that the era of the case series is over. It's time to stop doing case series and perform more controlled studies and preferentially randomized controlled trials. Thank you for your attention. I think I'm out of time. I don't think we're taking questions. I'd be happy to stay up if anyone wants to come talk to me. Thanks for attending.